for care to be impeded because we have to wait for the life of the mother or the life of the person who's pregnant to be at stake. Well, at that point, we waited too long. There's no other field of medicine where you wait for someone to be like severely, on their deathbed to act on them. Like the goal of us is to prevent that from happening. And to tie our hands and tell us we need to wait until that person's life is now threatened and in jeopardy it goes against our training as physicians.
The dreaded 2-week wait, that agonizing time between when you could be pregnant, maybe after ovulation or after an embryo transfer, but before you could possibly have a positive pregnancy test. The mental gymnastics of, is that implantation bleeding or the start of a period? And what was that cramp? Here to help us navigate this tough time in early pregnancy is double board certified reproductive endocrinologist and OBGYN from Spring Fertility in San Francisco. Welcome to Baby or Bust, Dr. Temeka Zore.
Hi, thank you so much, Laura, for having me today.
You and I have helped so many people through this really agonizing time. It's that time when you're just so ready to be pregnant and you can't test yet, or maybe you're starting to test, and patients are always asking us like, hey, how can I know? And I've been in this situation myself after embryo transfer, after ovulation. How do you guide your patients through this really tough time?
I completely sympathize with them because this is the most agonizing, brutal time is that 2-week wait, because the 2 weeks feels like 25 years to get those results. And so I always try and counsel patients to just try and keep yourself busy, whether it's picking up a new task or a hobby, staying busy with work or your friends, focusing on yourself, exercise, whatever can try to take your mind off of that stress of waiting for that 2-week time period.
What is implantation bleeding? When someone asks you that, how do you explain that to your patients?
Yeah, we talk about implantation bleeding in the sense that when that embryo is now in the uterus, when it's starting to implant in the uterus, you might have spotting. Usually implantation bleeding is different than a period because it'll be lighter, usually in color. It's mostly spotting to maybe a very light flow, and it lasts probably for less than 24 hours. Whereas a full flow period, you're going to typically have heavier, darker red bleeding. It might have clots within it, and it's usually going to be the length of your normal period.
I've had a patient I can remember very clearly just call me and say, all right, I'm stopping my medication. I'm having spotting, and so I know my period is starting. I'm starting to have cramping. And it was too early. She couldn't tell. And she was just like, yep, but I just know. And it's so stressful that it's you just kind of want it to be over. And sure enough, a couple of days later, she had a beautiful positive pregnancy test, followed up, and 9 months later, a beautiful baby. But she was just so anxious and so stressed. She just kind of didn't even want to see it through.
It's hard because a lot of the early symptoms when you might be pregnant are similar to when you might also be getting a period. And differentiating the two, it can be very tricky. It can be difficult. It's frustrating because you just don't know what's going to happen.
Sometimes what we're doing, the treatments that we're giving, is actually making them have more symptoms. Mm-hmm. So I've had patients on the other end. I remember very clearly a woman just giving me a call and just at her wit's end because she'd done 20 pregnancy tests and they were all negative, but yet she had never had a period that had ever gone past 28 days. Mm-hmm. And it was day 30 and she hadn't gotten a period yet. So therefore she's like, Dr. Shahine, I am pregnant. And I'm like, well, I hope you are. I hope all of those tests are wrong. But honestly, we're giving you progesterone.
Yeah.
And can you tell us why progesterone would maybe make this situation happen for her?
Progesterone, we're giving usually to supplement your own natural progesterone levels, but progesterone can prevent that bleed that you have. So if you are not pregnant, but you're still on progesterone, you might not get that period that you're expecting. Usually when you stop the progesterone, if you are not pregnant, you will then get a period within 2 to 4 days typically, but it was the progesterone that was just preventing that normal shedding of the lining.
I know, and we're also just making people have more of the premenstrual syndromes too,
Yep.
right? Because progesterone is what causes the mood swings and the bloating and
Yep.
the breast tenderness. How early can you do a pregnancy test, right? Like, don't you get asked that all the time?
I get asked that all the time. We have a lot of patients who ask about early testing, and at Spring, we tend to check our betas a little bit later than a lot of other clinics. And so we're checking usually 14 days after a transfer. By that time, theoretically, most people can do an early test and will get a positive. But there is a concern if you're checking too early. For instance, if you're doing certain types of cycles where you are triggering yourself with a medicine like an Ovidril, which is an HCG LH component, you can actually get false positives on home tests. So you don't want to check too early.
It is absolutely astounding how much it overtakes like every thought process you have.
Literally, I remember when I was pregnant, especially with my first pregnancy, that I like every sign, because you Google like, oh, what are these early pregnancy signs? Oh, I taste metallic in my mouth, I must be pregnant. Like, oh, I had some cramping, that could be pregnancy. And you're just paying such close attention to your body, probably more than you ever have before, that every sign or symptom you want to hope is what you're hoping for.
I try to talk to my patients about how every pregnancy can be really different. Some people will maybe do an embryo transfer, and between that and the pregnancy test, the first time that they tried, they had all of these symptoms, like they were nauseated, they had breast tenderness, they had implantation bleeding or spotting, and they got pregnant and had a baby.
Yep.
And so then they're coming back for a sibling cycle. They do the transfer, and after that transfer, they don't have any symptoms.
Yep.
And they're just absolutely convinced that it didn't work and like ready to stop early. And just, it's human nature to really kind of compare what happened before and make that assumption. Did you find that too?
Definitely. It's like what people do even with their children. They're comparing, like, one child did this, the other didn't. You're gonna do the same thing in pregnancy of, oh, I had this happen in pregnancy, but it's not happening this time. Maybe something's wrong. And we just have to remember that every pregnancy truly is unique in how your body and how you will respond to it.
How soon can you like really know that everything is okay? How do you counsel patients between now or in the next stage of that early pregnancy?
One of the benefits of patients who are in fertility treatment is that we tend to follow them pretty closely when they are early in pregnancy. And so we're going to know within 10 to 14 days, are you pregnant? And then if you are and have a positive HCG, we're going to know that number. And usually most clinics will repeat that in about 48 hours so that we can determine, is that beta rising appropriately?
There are times where the hormone level doesn't go up appropriately and everything's just fine, so we can like follow closely. Also, sometimes the pregnancy level goes up totally appropriately and things aren't fine. So it's like we're trying so hard to provide that reassurance, yet we're still driving people crazy. When is the first time in the pregnancy that you guys offer an ultrasound? Because seeing a heartbeat is really a huge goal and step in this process.
It is for everyone. We tend to offer first ultrasounds around 6 weeks and 2 days. I know there are a lot of clinics that do about 5 weeks and 2 days, and we're looking at that point for the gestational sac and that yolk sac, which looks like a little ring. But by 6 weeks and 2 to like 6 days, like in that early 6 week period, by then we usually are seeing a crown rump, and we're usually seeing the flicker of a heartbeat. And I feel like at that visit, it's giving patients like okay, this is real. We're seeing something, we're measuring. And so I think that gives a lot of people a sigh of relief, at least initially, until that next scan, of course.
So I talk to patients about when they have that first positive pregnancy test, that they're actually about 4 weeks pregnant, even if they're only 10 days after the embryo transfer. So the embryo's only been in the uterus for 10 days, or for you guys, 14 days. They're still dated by convention, which is basically like in air quotes, last menstrual period. You're about 4 weeks pregnant. And so there's this 2.5 weeks between, you have a positive pregnancy test and before you can really see anything on ultrasound that is just also agonizing. And we also tend towards doing the ultrasound at about 6.5 weeks. And the reason is if you come in too early, then it's just more ambiguity. And
Yep.
it's like so frustrating for patients. And I remember this too. It's like, just tell me, is everything okay or
Yep.
not? But if you come in too early, it's kind of like, well, we see some development, but we still have to wait a little while.
By the time we're seeing a heartbeat on ultrasound, that chance of a miscarriage significantly goes down. Probably well less than 5%, depending on your age, whether the embryo that you have is tested or not. But it just gives more information, more reassurance. Nobody wants to see bleeding when you are supposed to be pregnant. It's very common to see bleeding in early pregnancy. No one wants to see that. And so there's always this, what could be going on? Am I having a miscarriage? Especially if you've already had a history of miscarriages. Could it be a subchorionic hematoma? Is it constipation? Some people might notice bleeding and it could be constipation. Is it urinary? Hard to say. Most people know that if it is going to be vaginal, it's like, why is this happening? What's going on? Am I losing this pregnancy?
Yeah.
It's
Um,
terrifying.
yeah, I mean, especially if you've had a miscarriage too, you're kind of like waiting for bad news. And even just honestly going to the bathroom is triggering.
Yep.
Like, what are you going to see? Like, I know that's really kind of like visual and like visceral, but it's just like when it's you, if you're hearing this, you
Mhm.
know what we're talking about.
This is not something that you did to cause this. And it wasn't because you exercised or you had sex or you thought something bad or, you had a sip of wine. That is not your fault. This is not your fault. You did nothing to cause this.
So, what are some of the causes of first trimester bleeding? Like, if you do have someone that's having bleeding, how do you evaluate them, or what questions could they ask? If they're like, what's happening, Dr. Zori?
Certainly figuring out where you are, like, how far along are you? Is this something where we can bring you in for an ultrasound and potentially be seeing something? There are some causes of bleeding, like a subchorionic hematoma, which is kind of just like a big fancy word for like a little clot in the uterus. It's not that the pregnancy is bleeding, but the area behind the placenta, behind the sac, has some bleeding, and that can go into the cervix, and you can see that as blood that you're like wiping when you're going to the bathroom. There's not really a treatment or a medication we can give for that. Usually, again, it's just time. We tell you, no sex, pelvic rest, no exercise. And really, it's because usually when someone's noticing the bleeding, it might be because they've had some sort of pelvic engagement. Maybe it was sex. Maybe it was like you did a really, long run and then you notice spotting. And so it's just like we tell you to take it easy. But again, there's something that you did to cause that. That's not necessarily a treatment for that. It's just more like we're trying to make all of ourselves feel better so that we don't have to see this bleeding.
It's better to just rest to allow it to reabsorb. So if you do have intercourse, you do have heavy exercise, you're just probably going to see more bleeding, and it's just going to increase your anxiety more.
Exactly.
That's the way I try to explain it, because I don't want people to then think like, oh, well, maybe I should have been doing pelvic rest before then I wouldn't be in this situation. So I try to really kind of differentiate that. What are some other things that could cause bleeding in the first trimester?
Certainly, we kind of talked about before, whether it was implantation bleeding at that point, that may be not a factor anymore. Something a lot of people don't think about necessarily is like cervical bleeding. The cervix tends to become very like friable or irritated in early pregnancy. And so that bleeding you're having could just actually be cervical.
This has been a huge issue since the overturn of Roe v. Wade, right? There's so much medical information. I had a patient 2 weeks ago, absolutely distraught and bawling because we knew it was an ectopic pregnancy. And she said, can't you fix it? Like, can't you take it from the tube and put it into the uterus?
Mm-hmm.
And me just trying to explain, listen, I'm so sorry for your loss. And I know you read that online from a
Mm-hmm.
politician that talked about it, but that is not medically possible. Like,
Yep.
it's just, we need to take care of you and make sure that the pregnancy doesn't continue to grow, rupture the tube, cause bleeding.
I had a similar patient who we were kind of tracking betas, and it looked like it was going to be a pregnancy of unknown location. And then eventually we thought ectopic. And she's like, well, if I take methotrexate and it has a heartbeat, like that's an abortion. And I need to talk to my, religious leader about that. And I was like, there's a very big difference here, because if this is left in place and continues to grow, you could die. And being very frank, because this was a number one reason why women died in childbirth was ectopic pregnancies and hemorrhage in pregnancy, or preeclampsia when you're later along. And so we had to kind of explain like how this is not an abortion. This is a pregnancy that is just not sustainable with life. It can't grow in a fallopian tube. It will rupture.
I know. And that's why it's so important to have such a trusting relationship with your provider and being able to really connect and explain. It's just a really kind of confusing time for a lot of early pregnancy right now. I just had a patient today. She called me last night, absolutely convinced that she had miscarried. She had miscarriage before. She was about 7.5 weeks pregnant. Yesterday, just started spotting a little bit, cramping, heavy flow last night, called me in the middle of the night. I am sure that this is a miscarriage. I went through that whole conversation. Like, if I could fix this, I would send you to the emergency room. I would call in something, but just try to rest, go to sleep, and come and see me tomorrow, which is today. And she came in, she's just like, yep, it's been, heavy flow. I'm sure I'm done. I'm ready. And we did the ultrasound, and there was the beautiful heartbeat and the gorgeous pregnancy. And she just wept tears of relief, but also frustration. She'd already grieved, like she'd already let go emotionally of this pregnancy. Time to shut the door and move forward. So I also just really try to talk to people about, please just call your doctor. Don't make assumptions. Sometimes people will even, I hate to get kind of graphic here, but it's true. They'll be like, no, I saw the, something
Yep.
in the toilet or something
Yep.
like that. And it's like, hey, listen, blood clots, they can kind of look like tissue and they can look like things. And you just got to be sure.
Everyone asks, like, I'm having this really heavy bleeding. Like, I know I miscarried. And I can at least be that a person who says, like, I had very heavy bleeding in pregnancy, and my pregnancy turned out fine. I was able to have a healthy, full term delivery. And I know it doesn't always work out that way, but you can have bleeding in pregnancy, and you can go on to have a healthy pregnancy. And I think just having the hope that that could exist, because in the moment you don't feel that. Like, you were just like, it's done. And maybe we're doing that for a protective instinct, because it's almost, I don't know if it's easier or not, but it's just almost easier for me at least to just shut that door and be like, okay, that didn't work, and we'll try again when we're ready. But I certainly can sympathize with patients when they're going through that.
So, one thing I try to talk to patients about is how important it is to get that reassurance and to get that evaluation. And how many patients have told me, well, in the past, I've called other clinics and they say, we won't see you for a couple of weeks. And just trying to empower people to advocate for their care and just say, look, I really need to know, and maybe ask to speak to someone else in the clinic, or try to get that information, because just to be home and wondering and just in that limbo is just really, really hard.
It's so hard. And maybe because of my history, I'm very empathetic to anyone who's calling with bleeding. Like, if you're calling with bleeding and you're at least, again, 5 weeks and some change, and I can attempt to see something, I will bring you in next day or same day, depending on the time, to do a scan and put you out of that, like, what if misery that I know that you're in. I wish all of us in this field can be that empathetic to patients, to understand what they're going through. One, we need information. And just because you're seeing bleeding does not mean all hope is lost, is number one. Like, we have to try and stay hopeful and cautiously optimistic. I would give the same advice in terms of, okay, let's do pelvic rest. So meaning no sex for right now, no exercise, and anything that you could be doing, like if it's running, like let's just try and avoid that so you're not seeing more bleeding to make yourself more anxious. Again, knowing that sex and exercise do not cause miscarriages. I would always say, let's call your doctor and let them know. Because realistically, if you're over about 5.5 weeks along, if you do an ultrasound, a vaginal ultrasound, we should be able to see something on the scan. And it may not be, and I always tell people, if you're, before 6 weeks and some change, we may not see the crown rump length, the fetus, and no heartbeat, and that's okay. We're just trying to see milestones and make sure that you have a pregnancy in the uterus. And again, just trying to stay cautiously optimistic, and trying not to spiral, and not doing too much Googling on the internet, because that's, I think, where our mind just tends to go. Because you normally only see the negative stories. You don't necessarily see all the positive stories of, well, I had bleeding too, and it was okay. You're seeing that, like, I had all this bleeding and this is what happened, unfortunately. And so knowing that there's two sides to all these stories.
Something I was just telling a patient last week, because she's had bleeding, it's first trimester. She came in, everything looked great, but there's also not a reason for her bleeding. Like if there was a, ectopic pregnancy, that's why she's bleeding. If you could see bleeding on her cervix, you'd know that that was that. She hadn't had intercourse for a week. She also did not have a subchorionic hematoma, which kind of explain is like you said, like a bruise, a collection of blood kind of in between where the placenta is trying to implant and the uterus is trying to accept that, implantation. And so sometimes you'll see that and be like, okay, that's the source of bleeding. But for those times where you just don't see anything and the patient's like, where is that coming from? I say, listen, we don't always know, but it is amazing that not every single person has bleeding in the first trimester. If you think about how much that uterus has to change, how vascular it is, and literally that pregnancy is implanting, it's digging itself, into that vasculature. It's amazing that there's not more bleeding. Are you seeing any change in first trimester care or patients' perception for first trimester care since the overturn of Roe v. Wade?
Yeah, I mean, that was a hard time, certainly even in the fertility world, of like what happens to my eggs and embryos with this. And right now, like, I am fortunate to practice in a state that is very protective of a woman's right to choose and be able to have the healthcare she needs in California. But certainly the stories across the country, especially with first trimester losses, when you have a miscarriage, that is technically, the medical term is an abortion. You've had either a missed abortion, a spontaneous abortion, whatever that term is, and that term, that word abortion, has now been politicized. It's not just a medical term. It'd be like someone politicizing the word appendicitis, which sounds insane when you hear that, but that's what they've done to that word. And so now when people are trying to have treatment for their miscarriages, their abortions, pharmacies aren't able to prescribe the medications they need because they're the same medications that you may take for a termination, an elective termination, but you also need those for first trimester miscarriages. And so you've heard there's these stories of women who are suffering from miscarriages and can't get the medicine filled that they need to allow this process to happen, which I cannot imagine the turmoil of someone who has to drive to different pharmacies to find a medication to have them expel a pregnancy that was highly desired. And I think that isn't talked about enough when we have this conversation on like the overturning of Roe v. Wade.
Abortion just medically means that the pregnancy stopped developing. It doesn't say why, and it doesn't say whether it was intended or not. But the word abortion out in the public and in the media is an elective termination of a undesired pregnancy from someone who is flippantly not using contraception, right? And it is just, that is so few of the actual instances.
That's what happens when you put politics into healthcare, when they've lost sight of like patient care and these other scenarios that people need these medications for what could be very highly desired pregnancies, but the term is abortion. And so again, politicizing a medical term, it's just not fair. It's not right.
And it's people who really have no medical training or medical understanding trying to make laws that are really impacting medical care.
We feel so strongly because we've all trained, we've all gone through residency and fellowship and seen those situations where you have a ruptured ectopic and how significant and severe that can be and how much bleeding you can have if it's not immediately, quickly taken care of. And so again, for care to be impeded because we have to wait for the life of the mother or the life of the person who's pregnant to be at stake, well, at that point, we've waited too long. There's no other field of medicine where you wait for someone to be like truly like severely, on their deathbed to act on them. Like the goal of us is to prevent that from happening. And to tie our hands and tell us we need to wait until that person's life is now threatened and in jeopardy it goes against our training as physicians. I think having these conversations and sharing stories, one, it lets you know that you're not alone. You're not the only person going through this. And I think when you are going through this, that's such an important feeling to have, that you are not alone. And I would always tell anyone like who maybe is going through a miscarriage or has been through a miscarriage, going through fertility treatment, that you are not alone in this process. There's a whole community of people who may have experienced something similar to you. The more we have these conversations, the less stigma there is. And the more we I think, feel connected to each other and it doesn't become so isolating.
Absolutely. And the more stories we share about poor first trimester pregnancy outcomes and the delay in care, I think that could really impact people's voting decisions and understanding on a political level as well. I mean, that's what you and I are trying to do with Doctors for Fertility, the nonprofit that we started. As soon as Roe v. Wade was overturned, you and me and several reproductive endocrinologists around the country came together to figure out how are we going to protect the ability for people to do IVF and get first trimester care in a safe way and build their families. And so I appreciate all the work that you've done for that organization. And part of it is that story sharing.
And certainly everyone's story is going to be their own, but I know that I found when I was sharing my at least experience in the time when I, thought that this was not going to be going in a great direction. I had so many friends I found out who either had a recent miscarriage or were going through something similar that I had no idea. And again, it just brings you closer and makes you feel and realize that you are not alone on this journey, on this path.
Well, thank you for being here today. So how can we find you if we want to find you?
Yes, you can find me. So I'm at Spring Fertility in San Francisco. Also on social media, I'm Temeka Zore MD on Instagram and on TikTok. I'm trying to be just like Lora on both platforms.
I love your content.
And yes, and so excited to be here today. Thank you.
I hope you enjoyed that conversation with Dr. Zore today as much as I did. I really appreciated her words of wisdom during that highly anxious time in early pregnancy. If you are curious about what's happening, if you are nervous about the symptoms that you're having, do not hesitate to reach out to your medical provider and get your questions answered. I'm Dr. Lora Shahine, and this is Baby or Bust. Baby or Bust is produced by Mark Ramsey, Jamie Solis, and Greg Moga. Executive produced by Paul Anderson and Nick Piniella for Workhouse Media. Baby or Bust is a Mark Ramsey media production.